Bismillahirrahmanirrahim. So today I'm going to talk about a very important topic, that is hypertensive crisis. So how do you define the hypertensive crisis? That is acute increase in the blood pressure, systolic of 180 or more than 180 and diastolic of 120 or more than 120. That is hypertensive crisis. Now there are two types of hypertensive crisis. From the management point of view, we are having hypertensive emergency and we are having hypertensive urgency. Now all the things I'm covering in today's lecture, the reference is up to date and embossed. That is the USMLE studies. So if there is any confusion, you can ask me. Hypertensive emergency and hypertensive urgency. The hypertensive emergency, when the systolic BP is equal to or more than 180 and diastolic BP is equal to or more than 120, but there is end organ damage. This is very important to differentiate between the hypertensive emergency and urgency. Who needs emergency? Who needs urgency? So in hypertensive emergency, there is end organ damage. That is very important. By end organ damage, we mean CNS involvement, CVS involvement, kidneys involvement, these three things. So if a patient is brought to you in the ER with the high BP, you must go for these things. In the CNS, you should look for the hypertensive encephalopathy, and the stroke or the intracranial hemorrhage. So the hypertensive encephalopathy, a person is vomiting, person is confused. In stroke, depending upon the region, the patient is having weakness, facial paralysis, and aphasia, or the patient may be unconscious in the brainstem stroke. In the intracranial hemorrhage, there will be feature of raised intracranial pressure. So the CNS should be looked for these things. The CVS should be looked for the MI, acute coronary syndrome, aortic dissection. For the kidneys, we should look for acute renal failure. Acute renal failure. So a patient will have hyperkalemia, metabolic acidosis, pulmonary edema, and fluid overload. Hypertensive. Now this is hypertensive emergency. Regarding the investigation and management, coming to that in a few seconds. Now coming toward the hypertensive urgency. BP reading is the same, but there is no end organ damage. So the first thing is you are having hypertensive crisis. Now you are going to differentiate between the two. Either it's hypertensive urgency or emergency. So you have to find out end organ damage. So starting from the brain, what is going on in the brain? So you look for the planters upgoing or downgoing. You look for reflexes. You look for the size of pupils bilaterally and light reflex. And you look for the clonus in the lower limbs. It gave you idea about the stroke, about the intracranial hemorrhage. Unilateral upgoing plantar with clonus and exaggerated reflexes on one side. Think about stroke or intracranial hemorrhage. Something is going on in the brain. But if the plantars are upgoing bilaterally, so in deep coma, we can expect that. So you look for other causes such as severe hypoglycemia. You check the sugar of that patient. When in the deep coma, it is expected that the both plantars that can upgoing. In majority of the cases, there is usually pain withdrawal, and we take that as upgoing plantars. Well, there is not upgoing plantars. When you stroke that area, what happens? The patient withdraw the foot, but if you see the fingers, there is actually flexion. Withdraw the foot, but there is flexion. This is actually pain withdrawal, not the upgoing plantars. The size of pupil can tell you about whether something is going on in the brainstem or not. Whether something is going on with the brainstem or not. Third neuropalsy, and you should also go for the light reflex, whether the light reflex is present or absent. If both the pupils are constricted bilaterally, think about pontine hemorrhage. Think about pontine hemorrhage. Clonus, so if there is a clonus, think about something is going on in the brain. The CT brain will confirm that. Coming toward the eye, ophthalmoscopy. So you look for the retinal hemorrhages and papilloedema. So the papilloedema occurs in a chronic hypertension, but if it is present there, you should exclude the raised intracranial pressure. For the CVS, you should look for the radiofemoral delay. In aortic dissection, there is radiofemoral delay. Look for these 4 heart sounds, murmurs. Look for the GVP in the lungs. If there are fine corruption, the GVP is raised, think about acute LVF. So you go for ECG, echo, cardiac enzyme, and chest X-ray. It will clear the picture. Kidneys, we should go for the ABGs, RFTs, urinary, and serum electrolyte. So this is an overview of how to differentiate between the urgency and emergency. If single finding is present over there, take that case as hypertensio, emergency. And if all are absent, take that case as hypertensio, urgency. So if a patient is brought to you in unconscious condition and you take the blood pressure that is 220 by 110, you start immediately hypertensio emergency protocol. But you have to exclude first this thing, the stroke. Because in stroke, if you are reducing the blood pressure aggressively, you are actually killing the patient, provided that you are not giving thrombolytics such as tissue plasminogen activator, such as SK injection. In those conditions, you have to decrease the BP. So as a general rule, in case of hypertensio emergency, what should you do in first hour, next 2 to 6 hours, and next 24 to 48 hours? What should be your target blood pressure? So reduce the BP by 25% in the first hour. What you do, you take the systolic reading and diastolic reading and take out the percentage of systolic reading as well as diastolic reading and minus that percentage from that reading. Let's suppose, for example, a patient is having a systolic BP of 220. So what you do, you take the 25% of 220, that is 25 divided by 100 multiplied by 220. Whatever is the answer, you subtract that answer from 220. Now this is your target in the first hour, reduced by 25%. In the next 2 to 6 hours, your target BP should be 160 by 100. If not achieved by reduction in 25%. If already 160 by 100, keep it. Then in the next 24 to 48 hours, you should reduce the blood pressure by 130 by 80. Because with end organ damage, our target is 130 by 80. Without end organ damage, target is 140 by 90. But we are talking about hypertension emergency, that is end organ damage. So we should follow this algorithm. The guidelines for the stroke are different. So if the stroke is hemorrhagic or there is large intracranial hematoma, you should decrease the BP to 140 in first hour. The systolic BP should be lowered to 140 in first hour and maintain in the range of 140 to 50. 140 to 150. Why? Because if there is hemorrhage inside the brain and you are not lowering the BP, so there is the chance of extravasation of more blood in the brain, and there is risk of herniation. The brain herniates when there is raised intracranial pressure, when there is intracranial hemorrhage and you are not lowering the BP to this range in the first hour, so there is expanding hematoma in the brain. That expanding hematoma actually raises the intracranial pressure and herniate the brain stem through the foramen. If it herniates, what will happen? The brainstem is dead. When the brainstem is dead, all the internal processes such as heartbeat, blood pressure, respiratory rate, they all stop. So the target should be 140, but it should not be decreased more than 140. Target is 140. Keep in the range of 140 to 150. Why? Because if we are decreasing the BP from 140, if you are decreasing the BP from 140, so we are inducing an ischemic stroke. We are inducing an ischemic stroke along with hemorrhagic stroke. For ischemic stroke, we coming toward that topic. So coming toward ischemic stroke, this is a little bit tricky. If thrombolytic therapy is indicated, a patient is having high BP and ischemic stroke, and this is end organ damage. If thrombolytic therapy is to be given, decrease the BP to less than 185 by 110. And when you give thrombolytics, keep the BP to less than 180 by 105. Why? Because there is a risk of hemorrhagic transformation if the BP is more than 180 by 105 after thrombolytics for the first 24 hours. After 24 hours, the risk of hemorrhagic transformation is decreased. So these are the guidelines. We must follow them. If no thrombolytic therapy is to be given, the patient presented late, or the patient is having contraindication for thrombolytics, we are having two options now. If there is no end organ damage other than stroke, and the BP is less than 220 by 120, no therapy is needed at least for 48 to 72 hours. Why? Because if the BP is this much high, that is less than 220 by 120, or more than this, there is paralysis of auto-regulation in the brain. Brain cannot auto-regulate. Normally, in a normal person, if the BP comes down, what happens? There is cerebral vasodilation in order to increase the blood flow to the brain. Or when the blood pressure is increased, there is a vasospasm in the brain so as to decrease the blood flow to the brain. But if the BP is this much high, the auto-regulation system in the brain is lost. Now you have to control the auto-regulation from the outside. If there is no end organ damage other than stroke, and BP is less than 220 by 120, no therapy is indicated for 48 to 72 hours. Why? This time is important because after that time, the auto-regulation is restored, and then you can safely decrease this blood pressure. Option B is, if there is end organ damage other than stroke, that is MI or acute LVF or acute renal failure, our BP is equal to or more than 220 by 120. What is the best next step? Decrease the BP by 15% in first hour. Now this is very important. We have to lower the BP, we have to lower the blood pressure by 15% in the first hour at least. Not more than that. If we are decreasing the BP by more than 15% in the first hour, we are making more damage. We are making more damage, so we have to be careful regarding that. After decrease of 15%, in the next 2 to 6 hours, you have to maintain that blood pressure. You have to maintain that blood pressure. And for the next 24 hours, you have to decrease the blood pressure by 25% for the next 48 hours. And after 48 hours, you can safely achieve your targets, that is 130 by 80. But the most important thing is within the first hour. So in the first hour, you have to decrease the blood pressure by 15%. Now, what are you supposed to give to the patient to decrease the blood pressure. This is very important. Now, which drugs to be given? In case of hypertensio urgency, oral drugs. In case of hypertensive emergency, we give injectables. The duration is 72 hours to 1 week. In hypertensive urgency, you are not supposed to reduce the blood pressure aggressively because that has more side effects. The risks outweighs the benefits. So we give tablet Capoten 25 mg in the emergency department. It has rapid onset. It reduces the blood pressure, but the duration is of short time. And repeat the dose if the blood pressure is not reduced. This is a common practice we do in our emergency department. But I would rather say we have to look to the guidelines. The guideline says you are not supposed to lower the blood pressure in the emergency department in case of hypertensive urgency. Well, you have to take 72 hours to 1 week and start according to indication. But as our patients in the emergency department are very panic, so you can reduce the blood pressure but not aggressively. Let's, for example, say a patient is having BP of 160 by 100. You are not supposed to decrease the blood pressure by giving the Capoten. If the patient is having BP of 180 by 110, then yes, you can give the Capoten. But you are not supposed to bring that reading to the 120 by 80, 130 by 80. That has more side effects. But if the blood pressure is very much high, like for example say 220 by 120, yes, you can give the drug to reduce blood pressure a little in the emergency department, and then give the tablet according to the indication. For example, a person is diabetic, you give ACE inhibitors or ARBs. A person is diagnosed case of COPD or asthma, so you avoid the beta blockers and you go for the calcium channel blockers. A person is having heart block, so you should avoid the calcium channel blocker and beta blockers. So it depends upon the indication in the patient, and we have to individualize the patient according to the indication. So I would recommend not to aggressively decrease the blood pressure if the BP is not too much high. But if the BP is too much high, you can reduce a little in the emergency department and then give the medication according to the indication. Now the main bulk of the today's lecture is hypertensive emergency. We have to give injection labetalol or injection isokit. The labetalol comes in the dosage of 50 mg by 10 ml, and the isokit comes in the dosage of 10 mg by 10 ml. Now we will discuss the dosage. How can we give these two injectables in order to reduce the blood pressure? So there are two methods in which we can use injection labetalol to reduce the blood pressure. It comes in the strength of 50 mg by 10 ml. So the 0 cancelled with 0, so the 1 ml contains 5 mg. 1 ml of injection labetalol contains 5 mg of labetalol. So we are having two options: either give boluses or give continuous infusion, whichever you like. But continuous infusion requires frequent monitoring, 1 hourly, half hourly, and the boluses does not require that much frequent monitoring. So what we do in the bolus, we take 4 cc of injection labetalol and mix it with the 6 cc normal saline to give the final solution of 10 ml. Now this 10 ml contain 20 mg of labetalol. Because 1 cc has 5 mg, so 4 cc, 5 4 are 20. That is 20 mg labetalol, and we dilute it with the 6 cc normal saline, 20 mg, and we gave that very slowly. And then we check the BP after 15 to 30 minutes. If the BP is still high means we have not achieved our targets based on our previous discussion. We can repeat the dose, the same dose. Continuous infusion. So what happens? the dose is 1 milligram per minute. This is not per kg. We can increase to 2 milligram per minute. The actual dose is 0.5 milligram to 2 milligram per minute, but we usually give 1 milligram per minute in our emergency department. So what we do, we take 2 ampules of injection labetalol and mix it with the 80 cc normal saline to get the final solution of 100 ml, to get the final solution of 100 ml, because the 1 ampule is equal to 10 cc. So we have to discard 20 cc from normal saline, so that we are having 1 milligram per ml. In 100 cc solution, we are having 100 milligram of labetalol. So we are having 1 milligram of labetalol in each ml of solution. And now we set the dial flow at the rate of 60 ml per hour. At the rate of 60 ml per hour, and we are checking the blood pressure, monitoring the blood pressure regularly, so we can up titrate or down titrate according to the response. So if a person is having contraindication to the injection labetalol, let's for example say a person is having COPD or asthma, then you are supposed to use the injection iso kit, very commonly used in our ward, that is isosorbide dinitrate. Isosorbide dinitrate. And the very interesting thing is that it has a very short half-life. So if your BP becomes too low, you decrease the dosage, the BP will be normalized. If the BP becomes too high, you increase the dose and it will decrease the BP quickly. It has rapid onset of action and shorter half-life. It comes under the injection of 10 milligram by 10 ml. So we are having 1 milligram by 1 ml. So the dose is 2 to 12 milligram per hour. So we start with the lowest dose, that is 2 milligram, and titrate up according to the response. So what we do, we take 2 ampules and put in the 80 cc normal saline to give a final solution of 100 cc. We have to make the final solution of 100 cc. Now if we put 2 ampules in 100 cc normal saline, we will get final solution of 120 cc. So there will be confusion in the calculation. Now we are having 20 milligram in 100 ml, because 1 ampule is 10 milligram, so 2 ampules are 20 milligram. So 20 milligram in 100 ml, 0 cancel with 0, so 2 by 10. So the 10 ml contain 2 milligram, and our dosage requirement is 2 milligram. So if I start with the 10 ml per hour, I will get the 2 milligram. So the usual starting dose is 10 ml per hour. Now if I need to up titrate, like I need 6 milligram, I will increase the dose to 30 ml per hour to get the 6 milligram.